Hello, welcome to the Multifactorial's Risks for Falling in Parkinson's Disease talk today. My name is Elena. I'm a physical therapist and board certified neurological clinical specialist, and I practice with Adventist Healthcare Rehabilitation in the outpatient rehab department at White Oak Hospital in White Oak, Maryland. Today's objectives are going to be as follows. We're going to talk about what constitutes a fall, the risk factors for falling in Parkinson's disease, and also different aspects of falling in Parkinson's disease related to cognition and freezing of gait, and then also introduce the multidisciplinary team members and specifically talk about physical therapy's role in managing fall prevention and fall reduction. So fall, can you use it in a sentence? Unfortunately, we're not going to be talking about fall as it relates to autumn and the beautiful weather that we're having this season. However, we are going to be talking about falling as it relates to Parkinson's, where you may find yourself falling down on the ground. The World Health Organization's definition of a fall is a defined event which results in a person coming to rest inadvertently on the ground, floor, or other lower surface. So we're going to talk about this a little bit in greater detail throughout the presentation. Common explanations of falls that I hear in the clinic are as follows. I hear a lot of these very frequently, probably most of you have gotten the question, have you had any falls in the last month or the last 6 months from either of your doctors or from any of your therapists? And I wanted to stress that near falls are serious and are predictive of real falls or future falls. And they should be considered serious and reported to your doctor or healthcare providers if you're noticing a series of near falls. And that's really important and linked very closely with a real fall. So I don't want to overlook those near falls. The following are risk factors for falling in Parkinson's disease. We're going to go through some of these more specifically later on in the presentation. Right now, I wanted to touch on a couple of these topics, specifically higher medication doses, the second one down. Higher medication doses can cause what's called as dyskinesia, or an uncontrollable movement or writhing movement that we often think of when we think of Michael J. Fox and the type of movements that we see that he does when he's out in public. These movements, again, are uncontrollable and oftentimes can cause someone to be off balance if they're trying to move around while they're very dyskinetic. So if you're feeling this way, this is something to talk to your doctor about, as you may need to have a medication adjustment to minimize the impact of the dyskinesias. Further down, we're going to start at psychosis. We're going to kind of jump around this grid a little bit, unfortunately, but psychosis is something that some people with Parkinson's experience, not everyone, but lends itself to, unfortunately, seeing something in the room or in your environment that's not actually there. Very commonly, people see insects or animals in their environment, and you may be interested in going to try to get that animal out, but unfortunately, that animal is not there, or whatever image you're seeing is not there. So that could lend itself to being at greater risk for falling as you're trying to tackle whatever you see in your environment. Next, sleep disorder. This is very prevalent in people with Parkinson's disease. Some people have experienced sleep disorder where they have insomnia or have difficulty sleeping. And this can really impact your level of fatigue and your energy level, which conversely will impact the way that you're moving around, your strength, and your attention as well. Some other people may have experiences of sleepwalking. This is a situation where you're not conscious of your efforts as you're walking around, and that could additionally increase your risk for falling. Urinary dysfunction is something that a lot of people experience as they get older. May not specifically be related to Parkinson's, but may be a situation that's concurrent with your Parkinson's diagnosis. There are two different types of urinary dysfunction, or two different examples that I'll go through, one of which is an urge issue where you may all of a sudden really feel the urge to go to the bathroom, and this may cause some rushing or some quick movement to the bathroom, which could increase your risk for tripping or falling. And then conversely, some people may be feeling like they have to use the bathroom very frequently during the night. And this type of urination dysfunction could lend itself to having increased risk for falling, walking so much in the middle of the night. You want to make sure that you have a well-lit and well-maintained path to your bathroom so that you're not at greater risk for falling in the dark. The last one that we'll specifically talk about right now is blood pressure dysfunction. Many medications have side effects of lowering your blood pressure, and oftentimes people may feel symptoms of lightheadedness when doing or going through positional changes, such as going from a lying down position to standing up, or going from a sitting position to standing up. If you feel any lightheadedness during any position changes, I would strongly urge you to talk to your doctors, as this is something that could be related to your Parkinson's medication, or it could be related to a non-Parkinson related medication as well. So it's important to take a look at the side effects and make sure that you're not experiencing any lightheadedness. We'll talk through some of the other risk factors in the later slides. So talking through what the strongest predictor of falls, how can we predict, or can we predict a fall is going to happen, or when a fall may happen? And these different bullet points here are highly predictive of falls. So a history of previous falls. If you have fallen, then unfortunately you're at greater risk for having another fall. So this is one of the biggest predictors of falls, is as a presence of falling if you've had a fall before. That's why your healthcare team members oftentimes may ask you how many falls you may have in the last month, or how many falls in the last 6 months. Additionally, as your Parkinson's disease severity progresses, there's non-motor and motor symptoms that may change throughout that progression. So talking again about maybe needing more medication, that side effect of more medication could be the dyskinesia, as we talked about earlier. And then also some of the other symptoms that we talked about, such as psychosis, could also play a role as your Parkinson's progresses. Freezing of gait and fear of falling are also very prevalent predictors of falls. In the schematic on the screen, you can see that as you have a fear of falling, or if you have a low balance confidence, oftentimes people start to restrict movements or restrict activities, leading to avoidance behaviors. As we start to restrict activities or start to pull back from things that we used to do before in fear of falling, we become more inactive and we move less, more sedentary. And this in turn can increase your risk for falling, as oftentimes this impacts someone's strength or even further impacts their fear of falling. So if you feel like you found yourself in this cycle, I would encourage you to talk with your doctor or reach out to a physical therapist to see if you can have some help addressing your fear of falling. Cognitive contributions definitely impact your risk for falling and impact your freezing of gait. Cognitive changes, unfortunately, are inevitable as we get older and definitely occur over the progression of Parkinson's disease. And therefore, it is very closely linked with increasing your risk for falling and increasing risk of freezing of gait. This is because difficulty with the following areas of problem solving, attention and multitasking, memory, and specifically within problem solving, difficulty with that decision making and your ability to quickly make decisions on the fly. So for an example, if we think about going to a restaurant, which unfortunately is something that many of us are not doing right now, but if you even think about having more of a social distancing or sitting outside at a restaurant, outdoor dining, you may have noticed that due to the social distancing guidelines, the tables are more further apart. That may make it a lot easier for you to get around in the environment, in a community environment or a restaurant environment. If we think back to when we were eating indoors in restaurants, a lot of times the lighting may have been more dim, may have been a little loud, very busy, and we had to negotiate through tightly placed tables and booths, which caused some trouble, and some quick decision making needed to take place to figure out how we needed to negotiate around these obstacles. Especially more challenging is if you were using a walker and had to negotiate through those tight spaces. With cognitive changes, we end up having slowed reaction time and more challenges with those problem-solving activities, such as getting around tables or moving around in restaurants. So this is something that could increase your risk for falling when you're in busy, more challenging environments, such as a restaurant, and could even be a trigger for freezing of gait. Specifically, adding on to talk about attention, a very common example of someone who's fallen who may have had more challenges with attention is what I hear below. I was just talking and walking, but then all of a sudden I was on the ground. So this cues me into maybe someone was having difficulty assessing or with the problem solving aspect of walking in their surroundings while they were also paying attention to conversation. This is an example of divided attention or even alternating attention, which both of these tasks are much more challenging, higher level attention tasks. Divided attention is when we're doing two things at once, and alternating attention is when you're having to take that one step further and really pay attention to both of those things at the same time. Sustained attention is an example of an easier attention activity, and hopefully something that you're doing right now, which is being able to focus your attention on one task and really keep your attention on that task for a period of time. Sustained attention and selective attention are both examples of easier aspects of attention. All of these attention subtypes are on a spectrum where starting with sustained attention is much easier, going all the way to alternating attention, which is much more challenging. All of these aspects of attention are going to be targeted in many of the therapies that you would receive. That includes physical therapy, occupational therapy, and speech therapy. Freezing of gait. So what does it look like? A lot of people describe to me the feeling that they're stuck in the mud, that their feet are literally stuck in the ground. And despite their best efforts of telling their body to move forward, they're unable to progress or initiate their motion. Some people may have what looks like a fast oscillation of the legs back and forth, but are unable again to actually initiate or start that motion. If you try to push through it, this may lead to a festination, where your steps are uncontrollably in a fast pace, moving in a forward or backward direction. This, unfortunately, is very dangerous, as it's hard to stop that forward or backward progression and could end up leading to a fall. My best suggestion, and something that we'll talk about in the next slide, is to try not to push through a freezing of gait episode. Try not to lead into that festination so that you can avoid having that increased risk of falling. So triggers, what leads to freezing of gait? What are some of the risk factors or triggers for freezing of gait? Oftentimes, this is related to a difficulty with the problem-solving aspect and difficulty with cognition to be able to problem solve through a changing environment. So an example of this would be, say, for example, in your house, you may have some changes of surface type of the flooring. If you have a room that goes from a hardwood floor to a carpeted floor, through that surface change or that threshold of doorway, through that change, that may be a trigger for freezing of gait as your body tries to problem solve how to negotiate that surface type difference. Another trigger for freezing of gait would be turning. Oftentimes a very common place or common places in the house where I hear people having falls are in the kitchen, bathroom, closet, and bedroom. These are all areas where we have to do many turns and frequent tight turns in nature to try to grab items that we may need. Turning can really throw off our balance and challenge that problem-solving aspect of cognition. Off times of therapy could also be triggers for freezing of gait, whereas we're having less dopamine in our system and having it be a time that it's harder for us to move. This could be something that if you're tracking, you want to track to see if this freezing of gait episodes happen more frequently during the on times or off times of your medication. And that may warrant a good discussion with your doctor to help support any medication changes or to justify some of the reasons for your freezing of gait. Additionally, fear, stress, and anxiety play a huge role in freezing of gait. Unfortunately, this could turn into a really bad cycle, where if you've had a freezing of gait episode before, then you may be more fearful or more anxious when you start to feel a freezing of gait episode again, or more fearful or anxious of moving. And then when it starts to happen again, that increases that fear and increases that stress level. This also could be completely external. Maybe you just have more stress in your life, maybe some family stress, or even stress related to COVID-19. We're definitely all a bit more stressed right now, and even some of those external stressors could be a trigger for freezing of gait. Lastly, distractions are another risk factor or trigger for freezing of gait. As we talked about before, with cognition playing such a big role on how we're moving, any distraction really deters our focus from our movement and could impact or cause a freezing of gait opportunity. So strategies for freezing of gait. One of the biggest strategies I would say is to not fight the freeze. Don't lead into that destination. Don't let your movements get out of control. One of the best things is to stop in your tracks if you're able to. Hold on to something to get some more secure, to feel more secure in your balance. Take a deep breath and breathe. What we really need is to lower that stress, anxiety level, lower that fear so that we can have a clearer mind and be able to focus more on your movement to be able to initiate movement again. So that's really how the reason behind really employing those relaxation strategies and making sure that you're not fighting through the freeze. Once you feel like you've reset, in order to start walking or start your movement again, I recommend that you start shifting your weight side to side, shifting your weight from leg to leg. This helps to prime your prime your body for movement. Get your body ready to start moving again after you've stopped. Some people have benefit from using an external cue, so something outside of their body to help initiate their movement. Some people find benefit from a visual cue. So let's say you're stuck within that threshold or stuck in an environment, changing environment. Why don't you pick something out in the distance, such as a chair in the living room, and walk towards that chair? Some people like to count their steps or anticipate the number of steps it may take to get to the chair and then count it out loud to keep them on track and keep them focused. Some people like to have a tactile cue or a touch to their leg to help initiate that leg to start moving. Some people use that with their hand, or maybe they use their cane or something to touch the leg to get it to start moving. Other people find benefit by using an auditory cue or a sound, something like a metronome or something like counting out loud so that you can help prime your body to start the movement. Some people like to count to 3 and on 3, start their walk. Okay, so it's something as you're shifting back and forth, 1, 2, 3, and start on 3. Those are all good strategies to kind of get yourself out of the freezing cycle. Another recommendation would be to look around your house and try to minimize the amount of clutter or obstacles that you have to get around. This would minimize the amount of problem solving that you have to do and lower your risk for falling. An example I'd like to share is much like if you have your computer freezing, you may see the symbol in the bottom right-hand corner. That's a symbol that shares that the computer may be in a freezing episode. When that happens, oftentimes what we do is press the button many times to try to get it to restart or to try to get it to get back on the page. However, oftentimes that doesn't really work. In fact, it slows the computer down even more. So this is an example of really trying to push through your freezing episode. If you're trying to push through the freezing episode, it's not going to work, and it may put you at greater risk for falling. So much like the computer, you want to Control Alt Delete and reset so that you can have less overwhelming thoughts, less overwhelming fear and stress, and be able to move much more freely and easily. Additionally, vision can impact our balance, our way of movement, and increase your risk for falling as well. Unfortunately, we have dopamine all throughout our body, and dopamine is also present in our eyes. Dopamine is the neurotransmitter that is affected by Parkinson's, and as we have depletion of dopamine, we can have changes in our vision due to the lack of dopamine in our eyes. This can result in changes in depth perception, changes in color contrast, how we see color, and cause some double vision. If you're having changes or issues in any of these areas, I would strongly encourage you to talk with your doctor and see if you maybe benefit from having a screen with a neuro-ophthalmologist to see if that could be helpful for your care. So what about therapy? Where does therapy come in? Physical therapy specifically is going to work on balance training, going to work on assisted device training. We're going to work on your posture. We're going to talk about strategies, suggestions, and tips for on and off times. We're going to work through those big movements, working on amplitude. Sometimes, or for many people in Parkinson's, those movements get smaller, and we really want to work on making those movements bigger. That's in addition to for supporting your walking and supporting other movements as well. We want to work on your walking and your gait training, and then specifically working on that divided attention or that cognitive piece and how it relates to walking as well. So we want to work on balance and walking, walking and talking, walking and thinking, walking and carrying something, to try to make that a lot easier for you in the relation between your cognition and your movement. And lastly, we're going to work on the safety awareness piece as well. Now, you may find that there's some carryover between occupational therapy, physical therapy, and speech therapy as it relates to all of these strategies. And there is some carryover, but we also have some differences as well. Speech therapy is going to work more specifically on the cognition and those different levels of attention that we talked about. They also work on speech and language production and voice amplification. However, that's not specifically related to balance, but I wanted to make sure that that was on the slide as well. Occupational therapy is going to look more into your vision, work more on your fine motor control, and talk about your activities of daily living and how your walking, your balance, or your movements may impact those. So when should you bring it up? When should you talk about the challenges that you're facing? I always suggest that prevention is much better than reduction of falls. Remember, in the beginning, we talked about once you've had a fall, you are at greater risk for falling again. So I would encourage you to talk and speak up, advocate for yourself, and talk about if you're having any of the issues that we talked about today, talk about those with your doctor, your medical team, specifically your movement disorder specialist, to see if you may benefit from seeing any other specialists in the multidisciplinary team, as we talked about on the last slide, any occupational therapy, speech therapy, or physical therapy. You want to think about and track when you are having your falls or near falls. Does it happen to be during an off time more consistently? Or does it happen to be on an on time and you're having more of those dyskinesias? That's something to note and would be very beneficial to have a discussion with your doctor about. Lastly, you want to also look at those non-Parkinson medications and rule out any side effects that those may be having on your balance, your cognition, and make sure that you talk with your doctor, whether that's your primary care doctor or your Parkinson's doctor, about any of those concerns. Here are my references. And thank you so much for coming to this talk. I will be open to questions and look forward to hearing from you. Thank you so much.
Okay, at this time, I'm going to welcome Elena to answer any of your questions.
Hi, everyone. Hope you enjoyed the presentation. Love to take any questions that you may have.
Hi, I'm just checking in to make sure you can hear. My name is Trisha.
I can hear you. Yep.
Thanks. Could you advise on the use of Nordic walking sticks as a way of possibly preventing falls? And if there's a difference between using them on streets, concrete, etc., versus grass or trails? Thanks.
Absolutely. That's a great question and something that has been brought up to me before in the clinic. I think to answer your question, it really depends on the level of each individual and how much balance challenges they may be having. I think the Nordic poles, where if everyone's not aware, it's a hiking stick kind of looking device that's much taller than a cane and that you'd hold in both hands, like having a hiking stick in both hands. For someone who is more active or is having just beginning changes of their balance, this can be very beneficial. And actually something that I advocate more than just using a single point cane or a one-sided cane, as having hiking poles in both hands can help to facilitate more of a reciprocal gait pattern, which is what we want to maintain as long as we can. So getting both arms swinging and using both arms, both legs in coordination. A lot of times when we're using a cane, one cane, that coordination kind of can get thrown off. And then that's yet another thing that cognitively you have to think about while you're walking. In response to the different surface types, I think as long as you have variable bases on the Nordic hiking sticks, so sometimes they can come with more of a pointed base if you're doing more like hiking or walking over grass, so that it actually can stick down into the ground and give you some more stability. But then I think you don't really want that pointed piece if you're just walking over cement or over kind of tar-based surfaces. So if you just have more of like a pointed bottom, or I'm sorry, more like a cane tip bottom, then that's more successful on those types of surfaces. So definitely if that's someone that just needs a little bit of balance help, a little bit of steadying, especially when you're going in those variable surfaces, I highly recommend it, especially over a cane. However, if you're getting up to the need of maybe needing a walker or something more sturdy, then a walker would provide more stability than the 2 walking sticks would. Hopefully
Great.
that.
And I just wanted to add that we just discovered a really helpful thing for my husband's glasses, which because of wearing the mask, were steaming up and fogging up while we were walking. Another unintended risk. And you don't really want to have to stay home because you're having vision issues. So he found these film papers from REI, and they reduce the buildup of fog essentially. And they've been on the market for a long time for skiers to clear off their goggles when they're skiing. But we discovered that they actually do help a lot when you're wearing the mask and walking.
That's fantastic. Thanks for sharing that. As a skier myself, I haven't needed to use those, but definitely have encountered the spray, and absolutely that's a huge contribution to your vision and being able to see clearly. So thanks for throwing out that tip. Any other questions?
Alina, there's one in the chat that says, any suggestions to help a person know how to use railings? Maybe? Yeah.
Okay. Do you mean whoever wrote that question? Feel free to clarify if you mean railing.
That would be me. Any suggestions to help a person know to use the railing, because it's a new thing with falls. So he promised the doctor that he would use the railing, but he has not today, or, so how to make a new habit, any ideas on that? Thank you.
Yes, so making a new habit is tough, especially as you've gotten into maybe the later stages of Parkinson's. I would recommend that it is maybe a little tough as a caregiver, as a family member to be there and always give that reminder. But I think in the beginning, as we're learning a new thing or trying to establish a new pattern, having that external reminder is going to be very helpful, especially if it's in a more stressful situation, like if you have fallen and now trying to compose yourself and get back up. I would definitely encourage in the beginning stages of this being a new activity that he's trying to learn, to try to just give some suggestions and reminders. Also, it could be a good thing to put some bright tape on it. As I talked about in the talk, that color contrast can really be challenging for people who may be having some vision changes related to the Parkinson's. So having maybe some bright, Scotch tape or duct tape on the railing itself, then you can be like, why don't you reach for the pink or red tape? Reach for that yellow tape. That can provide a reminder as well.
That's great. Thank you.
You're welcome. I see in here, maybe that was in response to that question, if it's a new activity, would home therapy be a good idea? I would definitely suggest that if you're having a lot more falls, that having, whether it's appropriate home therapy or outpatient therapy, would be very helpful, and being able to try to help reinforce learning that new strategy. This was a large topic to cover, and something that probably could have talked a long time about. So would
go ahead. She
definitely
can.
Elena, it's Ron.
Hi.
I miss you.
Miss
Just wondering
you too,
what you think of the rollator. Does it possibly cause falls or prevent them?
I would say in general, a rollator should prevent falls if you're using it correctly. So you always want to keep it really close to you. Don't let it get too far away where you're stretching your arms out forward. And as long as you're keeping it close to you and standing up nice and tall, it should help to reduce falls. However, again, kind of going back to that presentation, once you're at the level of needing some more balance support, you may be having some more balance issues in general. So I don't think that if used correctly, the rollator shouldn't be causing falls, but there may be some other things going on that are causing the falls.
Thank you.
Does that help?
Maybe
Yes.
going from carpet to floor, you know, off of unlevel area, that could be tricky, or the carpet. That's what I notice.
And the rollator in that aspect is a lot better than a rolling walker. So the bigger wheels of the rollator will help to cover those surface changes a lot better than a standard walker or a rolling walker. So definitely something to think about while you're considering an assisted device. It would be really helpful to talk with your doctor or a therapist if you're seeing one, to talk through some of those surface changes and your balance challenges and really decide which assisted device would be the best for you. There are also lots of different types of rollators. It seems like now the market for assisted devices is changing very rapidly. So specifically for Parkinson's, there's an up walker and a U-step walker, which are also types of rollators that are a little bit more expensive, but could help for someone who has even more balance challenges or negotiating around the environment. So things to look into as well. You have your standard walker, a rolling walker. Those are kind of the metal, aluminum based walkers that were more typical, more expected to see. A rollator is the one that has brakes and a seat. So it's really helpful if you need to take a break and sit down. You can kind of whip it around and have a surface to sit on. And then there's also the U-step walker and the up walker.
Thank you, Elena. This has been wonderful. Just a reminder to everyone that we will be sending out the contact info for all of our speakers today in case you have any follow-up questions. We do have just one final session that remains. That's closing remarks. So in just a few minutes, this will actually, in about a minute, this session will close and we'll return to the webpage for one last session. Thanks again, Elena, for everything.
Thank you, guys.